name is Dr. Jenna Stevens. I'm a consultant anaesthetist. I'm the lead for the Clinical and Health Service Planning Workstream within Aneurin Bevan University Health Board's Decarbonisation Programme Board. Apologies for not being able to be with you in person this evening, or virtually in person. But hopefully this presentation, a recorded presentation, will highlight the work that we've been doing within Aneurin Bevan and hopefully help um, sort of sort of take the work with Entonox mitigation further forward within the UK. So the specific work that I'm going to talk about is the work that I have been doing alongside my colleague Rebecca Clement, who is a midwifery safety champion. And in fact, Rebecca's really done a significant amount of this work herself, so really should have the credit for this. We were very keen to have a destruction unit within our maternity services within Aneurin Bevan, but we also wanted to show that actually the destruction unit sort of did what it said on the tin. So we put in a business case for funding for a destruction unit and also for a nitrous oxide detector, because our project outline was to look at the Entonox levels or nitrous oxide levels um, within a labour, and then compare those to the levels once the mobile destruction unit was in use. So we sought support from our birth centre staff at one of our new hospital, the Grange University Hospital. We sort of spoke to them face to face and also produced a resource folder for them. Once we had the engagement and the staff were happy to take this project forward, we chose the pool room on the birth centre. The reason we chose this room is because we felt that we would be able to capture more data fairly quickly, because ladies tend to deliver in that room and then move to another area. So we'd hope to get the throughput of a number of different labours. So the setup is as states there really. So we placed our nitrous oxide detector 70 centimetres from the floor and 80 centimetres from the Entonox outlet. And it was not moved at all during the entire evaluation period. And just for background, the nitrous oxide detector records a lot of data. It records one data point every 15 minutes. So alongside that data, we also asked the staff to log Entonox use via the QR codes, which were available in the delivery room itself. So our baseline data, so prior to using the destruction unit, is shown on this slide. So we obtained data for 14 labours. Median length of recorded Entonox use was 180 minutes. And we've looked at data of maximum parts per million recorded and also the number of readings over 100 parts per million. So the graph on the left shows the maximum parts per million per labour, sorry. And that range was between 78.6 to 705, with a median parts per million per labour of over 200. The graph on the right is illustrating the number of readings over 100 parts per million for those labours. And you can see there's a range there between 0 and 17. And the median number of readings over 100 parts per million was between 4 and 6. So our baseline data tells us a measure of environmental levels, not personal exposure. But it also shows that 92% of labours crossed the 100 parts per million threshold. We chose that as a significant level because that's the 8-hour time weighted average for personal exposure. So that's from cost regulations and also within our Entonox safety data sheet. Good news is that there was no Entonox being detected when it was not in use. And we could correlate that to the data from the QR codes that the midwives were entering. So and actually the levels fell off fairly quickly once Entonox has stopped being used. So it shows our ventilation system is very efficient, reassuring for health and safety, but not necessarily for the environment. And this is the data for when our mobile destruction unit was being used. So we recorded data for 18 labours this time. similar median length of recorded use. And you can see the comparison with the baseline data on the left and the MDU in use data on the right-hand side. And there's a significant reduction in the parts per million, or the maximum parts per million recorded per labour. So the range now is between 0 and 151 compared to 78 to 705. And in fact, 12 out of our 18 labours, we recorded 0 parts per million of Entonox. There are some sort of peaks and blips within the data, and that we correlated to when the ladies were not breathing correctly, so not expiring through the mouthpiece, or I believe one lady used the bathroom, so was not able to expire through the destruction unit. And then we compared our baseline data again on the number of readings over 100 parts per million per labour, and then looked at the same number of readings when the MDU was in use. And the range here is now between 0 and 3 compared to 0 and 17 from the previous baseline. And actually only one labour crossed the 100 parts per million threshold. So that's now 6% compared to 92% in the baseline group. So we drew some conclusions. So the MDU significantly reduces environmental Entonox levels in the labour room that we studied. And we'd like to now ensure validity across all areas that we use Entonox and use the mobile destruction unit in other birthing rooms. I've got some calculations there based on the information in the first slide. So theoretically, a mobile destruction unit can scavenge 70 to 75% of expired Entonox. So we can significantly reduce the carbon footprint of a birth with Entonox by using a destruction unit of some description. But also we need to be thinking about other options. So are there alternatives available? So Penthrox potentially after delivery. And also if a lady's requesting an epidural, we should really try and as an anaesthetist certainly cite that within a very timely manner. And also education for the midwives and also for the users of Entonox. So again, apologies for not being able to be there in person. I know obviously a very whistle-stop tour of the information, but please do get in touch if there's any questions, comments, or anything, any way we can help you in your hospitals. Many thanks, and I hope you enjoy the rest of the webinar, and I do look forward to listening to the recording very soon. Thank you. Good night.